Good morning, colleagues, and it's one of the very exciting instruction course. Unfortunately, it's in the morning, early morning, because corneal emergencies are a real challenge for general practitioners. For us, it's all right. For general practice, they should know what are the emergencies which can happen. And I'm going to cover something on a refractive surgery. We know that it's quite rare to have emergency situation in refractive surgery, but we do have things like that. So I divided this into two areas. One is the incisional surgeries, which we used to do earlier, which can be a rupture, acute hydrops, keratitis. The other more important one is the ablative procedures, which can have either flap related or interface related problems, which may be seen in all types of refractive surgery, including the lenticule based procedures also. Briefly on a radial keratotomy, we can still see those patients, especially with the multiple incisions, the incision going across the limbus, depth which is more than 90%. You can have even after 20, 30 years, you can have complications, and sometimes they require immediate attention, especially if there's an injury with the either blunt injury with all the incision can open up like a flower pattern. And this is one example of one of our patient who had RK done long time back, and he had 6 RK incision, and they opened up all of them, and we had to put radial suture to all of them. And this is after 1 week, and see the entire central area is not very good, and the vision was very poor. 6/60 did not improve subsequently also. And sometimes these patients can have, hydrops, which Sunita talked about, and infectious keratitis also. More importantly, if you have an infection in these RK cases, it's very difficult to take off because they are between the incisions and they go deeper. And apart from the treating the infection, you have to treat the gap which has occurred in this. So we have described this technique of putting, apart from cleaning the infection, we have to put a bursting suture in these so that the gap can also be taken care of. This is what Dr. Sunita talked about. We had few cases of hydrops in a post-RK patients, which requires immediate attention by intracameral injection of gas or air. That time we didn't have the idea of suturing now, and I think now sutures may be better, like multiple suture what Sunita talked about. Here also, if you can do a bursting type of suture, which will be helpful in these cases, apart from the suture over the area of defect, which can be done. In fact, in RP Center, our colleagues are doing now AIOS2025 guided suturing in all hydrops patients, and that seems to help better. And on the table, you can judge where you have to put suture in these cases. In the post-op also, I think Sunita did talk about that. If you have OCT guided appearance, then you can realize which area still is not healing, then you can titrate your suture removal in those cases also. Let's talk about the LASIK emergencies. As I said, it can be flap or interface related. Flap related, you all know, on the immediate after surgery also, you can have a macro folds. Normally these are seen, the next day. But classically what we do after we do LASIK, we do examine these patients before we send them home, because sometimes immediately after surgery patient might touch it. At that time the flap is weakest in terms of adhesion, and you can have microfold in these patients also. This is one of my patient came after 1 day of a surgery. Normally after 1 day also you have to remove the epithelium. If you have a folds, epithelial removal is compulsory in these cases, otherwise you can never take off this. The only thing which difference in the early onset folds and the late onset folds is, in late onset you may have to lift the entire flap, and you can iron out from both anterior and posterior side of flap. Here, because it was just within 12 hours, I did not lift the flap. I could still manage by massaging this without disrupting the interface. Because once you disrupt the interface, the chances of epithelial growth becomes very high. So that I could manage in this patient. Classically, I would say, even it is within the first few hours also, patient comes back, you may have to remove epithelium, otherwise you can never iron out the folds in these cases also. Other thing which we see long term is sometimes the flap dislocation because of injury, which may happen because of inadvertent or sometimes fight, which normally these people are psychologically driven like that. They don't really restrain themselves from other things. They are a different group of people. So this is one of my patient came to us, during COVID time, had an injury and came after 13 months after injury. He had a 4 by 60 vision at that time, and he had a thick area of epithelial growth. Entire flap had shifted. This is the margin now. This was supposed to be the flap area. This is the fibrosis which happened over the surface. And you can see so many folds, which are fixed folds are there. In fact, this patient we took, this was the topography of a patient, how thick the cornea had happened and caused steepness there. And this is a thick epithelial growth there. And this patient, I'm just showing that because sometimes you may have to sacrifice these flaps, which has become totally redundant. We'll never be able to flatten this and cover the entire area. So with the OCT eyes guided, we took out the epithelium first, removed the entire flap, and detached it. Like this is what I'm taking. You can easily tear off from here. Then after that, I applied mitomycin C, removed the entire epithelial ingrowth, because these emergency situations has to be dealt before this epithelial ingrowth goes deeper. Also, flap is definitely going to be distorted here, and I've removed this. You can see the surface has become smoother now. The idea here is, despite removing the entire this thing, put mitomycin C, and this is the end of surgery. Next day, the patient had a 6-9 vision, where the flap has been totally sacrificed, and best corrector was 6-6. And this patient now with me for last 2 years, and vision is 6-9 parts without any flap over that also. The flap normally doesn't give you too much a refractive addition. This is the mapping now. As you can see how smooth the cornea has become, little bit of cylinder, but quite smoothly done now. This was published in IGO also. The other is a LASIK epithelial ingrowth, not an emergency, but cases which are approaching the visual axis, or ingrowth is threatening to approach visual axis, or there is a threat of a flap melt. So that should be taken care of immediately if possible. These are various ways to tackle epithelial ingrowth. This is one of our patient had a thick epithelial ingrowth approaching the visual axis. So these cases you have to tackle. Don't wait for a longer time, because ultimately this is going to cause a visual disturbance. Once the flap melt occurs, the things become very difficult subsequently also. The idea here is to identify the edge of flap, which normally I do. This is our technique of pressurizing the center. This highlights the peripheral area. I can easily take this space there with a Sinskey hook. So you are at right space, and this dimpling effect gives you a lot of advantage in all cases. So I have lifted the area, partially lifted here, because you don't have to lift the entire area. I've lifted up to pupillary axis so that this epithelial ingrowth can be taken off, and put a mitomycin C and alcohol treatment, and deposit this flap subsequently back. This is the end of surgery. You can see very nice smooth surface, and the flap also has been taken care of, and you can deposit back. And OCT also guides how good a position is by seeing the peripheral area also. This is after 1 day, and now patient is again with us for a long time, and with a good outcome in these patients. So this is a technique of AIOS2025 guided epithelial ingrowth management if it is reaching up to the visual axis. But most important concern for us will be a microbial keratitis post-refractive surgery. And it is a disaster complication which can happen after PRK, epiLASIK, LASIK, or a SMILE also. Incidence is quite less now, especially with the use of femtosecond flap making. It is much more with the microkeratome assisted surgery, especially where people use one blade for multiple eyes. That can be a cause, and atypical mycobacteria is one of the important association. You can see the large number of cases are atypical mycobacteria. Otherwise, staph, fungal nocardia, gram-negative can also be there in these cases of a series of cases. As I said, surface interface contamination may be one thing, but epithelial defect, if it happens, that can be a resource of infection. Microkeratomy seems to be a highest incidence of keratitis happening in these cases. It is very important to pick up early, and flap lifting if your things are not getting corrected, and scraping from underneath the flap and over the stromal area is very important to recognize the organisms and treat these. And sometimes atypical mycobacterium can be very difficult. This is a patient long time back. We had done epiLASIK, and this happened totally in the one eye within 2 days, and we had to do a large therapeutic graft in this patient. So sometimes it can be really devastating, but we did gain a 4 by 60 in this patient. Ultimately, Patient regained some vision after resurgery in these patients. This is one patient of mine, came with a small area of looked like infectious keratitis, but looked like a fungal. Ultimately, a flap melted with despite our treatment. Had to do a therapeutic graft subsequently. This is one more patient. Again, ICK type of picture increased. I did a DALK in this patient, did very well for 6 weeks. And again, the interface infection came up, and ultimately, we had to do a therapeutic graft. This came out to be a mycobacteria. Subsequently, earlier looked like a gram-positive organism. Sometimes multiple, organisms can be there in these cases also. So these are outcomes for various cause of diffuse lamellar keratitis. Sometimes it may be required emergency management. If your steroid treatment doesn't work in these patients, you may have to lift the flap and treat these cases accordingly. The other thing can be, intrastomal induced pressure, where you can have a fluid pocket there. Patient vision may be dropped immediately, high pressure. If you control the pressure, this goes up. The detection has to be done early in these patients also. To summarize, modern day refractive surgeries pretty safe. We don't get all these complications. I've hardly seen patients with infectious keratitis now in last 10 years. We shifted to femtosecond assisted surgeries. But we do see, sometimes episodes of these cases coming to us where microkeratome blades are still used in the peripheral areas. Prompt diagnosis, urgent management, which is required in these patients, especially a refractive surgery patient where integrity of visual acuity is important, but psychologically this may be really devastating sometimes. Thank you for your kind listening.
Thank you, sir, for this very informative lecture and practical aspects on management of refractive surgery associated corneal emergencies. We very frequently come across patients who have got these refractive surgeries done at some centers, higher centers, or some other centers, and then they're following up with the local ophthalmologist, and it becomes very important and pertinent that we are also aware of such cases and how to manage them judiciously and timely. Thank you, sir.
Okay,
Do
thank you.
we have any questions from the audience for sir? Yes, sir.
अच्छा बोल दे कोई है नहीं यहाँ पर.
We can we replace it with another kind of a femto flap, or
Yes.
what are the principles of that? I mean, it's always simple, amputate the flap,
Okay.
but I have a patient of like fixed folds. I've sutured it. It's a free cap, operated elsewhere, and maybe this is the way out for him. But there are some.
No, no, Amit, a very good question. It depends what type of patient we are dealing with, what type of flap dislocation or flap irregularity we are seeing with. Like free cap, we know sometimes happens on the table, and normally we normally like to retain those flaps because people have done suturing of these flaps. Perfect orientation should be there in these cases, and it normally does help because the early stages you should maintain the flap if possible. If it is a long-standing scar like this patient, where it will be difficult to reposit this flap and have a same area coverage because it's shrunken type of flap, it will never be useful in these cases. And once you have an epithelial ingrowth there already, so this will never take care of that area also because that has to be scraped off, and it's not good idea to put something else on this. I thought of this. Suppose this patient would have done very poorly, lot of irregular surface. I would have gone for a procedure where I would have put a, either ALTK type procedure, put a new flap corneal tissue over this. But this patient surprisingly did well in these cases. The corneal thickness around 380 in this patient, which was quite good enough for this case. But other way around, we have done a lot of publication in that post-LASIK ectasia patients where we amputated the previous flap and put the another tissue because the surface there is very smooth. It's like an automated surface. So we have put the around 250, 300 micron over that and sutured on that like an epikeratoplasty type of thing. So that can be done, and not always should sacrifice. You can manage these, cover the entire raw area. You should retain the flap possible.
Thank you, sir.
Yeah, thank you. Okay, any other question? I don't think many people are there. Luckily, I've done smile for last now 8 years, and no cases of infections. I had one case of epithelial ingrowth happening near the incision area that could be managed very effectively also. So maybe all these lenticule-based surgeries are safer than other procedures. I've seen infection in post-PR case, infection after LASIK, both the femtosecond and microkeratome. So whenever we are making the exposed area, I think the chances of infection are much more in those cases.